My topic is for the today is brachial plexus injury reconstruction, what has changed and what hasn't. I was honored to be continuous selected as the chapter author for the title of the brachial plexus injury in the fourth version of the textbook of plastic surgery, 2006, 2012, 2018, and 2024. In the book, Operative Brachial Plexus Surgery, Johnny Lu and I make a preface the chapter, historical perspective. I classify the brachial plexus injury reconstruction into the four periods. The period of recognized, this is before the 19th century. Periods of pessimism, people try to repair, but poor result. And period of improvement, because of microscopic application. And another period of improvement, because of nerve transfer and the function-free muscle transplantation. In the conclusion of that article, I say the history of brachial plexus injury reconstruction has evolved over the 3 centuries and has had a dramatic change in attitude from pessimism to optimism. Today, I'm talking about what has changed through my more than 35 years experience about the brachial plexus injury reconstruction. Here I list a change in terminology and another a change in the surgical treatment. Of course, those changes from my point of view. Start from the first change. It is post-ganglion spinal nerve. There actually is no post-ganglion root anatomical term. In the earlier book, such as 1985 from Robert Leffer, he used the okay, it's not difficult. Oh, here. Can you see that? Oh, okay. He showed this is the dorsal root rooted, and this is the ventral nerve rooted in the early book. However, in the late book, Alex Shin in 2021, they also show this is the anterior rooted and the posterior rooted. I say it's wrong. When you see the gray anatomy, the rooted is come from the great fiber from the great matter with the neck axon, and the white fibers from the white matter with the neuronema sheaths. The inside the pia mater, they cannot make suture because of very weak sheaths. Roots is come from the rooted, is inside the arachnoid matter. We call the subarachnoid space. They are filled with the central spinal fluid. The suture also very fragile. And the spinal nerve is combined anterior and posterior root with neuroma inside, sheath inside, and epineural sheath outside. Then you can make a suture. Simply saying, intraforamina is kind of the central nerve system. It actually belongs to the territory of the neurosurgeon. Extraforamina is kind of the peripheral nerve system. It belongs to the reconstructive nerve microsurgeon. The pia mater, which make endoneurium, and the dura mater make perineurium, and epidural connective tissue make epineurium. So you can see the CSF fluid. This is the ventral root. It's not rooted, it's root. This is dorsal root again. This is not rooted. The same from the MRI, also in the CSF fluid. Those are root, they are not rooted. They move to the second terminology of the brachial plexus, level of the classification of level of brachial plexus injury. There are so many, there are some pioneers of the brachial plexus reconstruction surgeon. They use a very complex term and a very confusing term. Preganglion, postganglion, supraganglion, infraganglion, and root. Then finally, change to the spinal nerve, touches, essentially another. Such kind of the classification is very complex and confused. And when you see the some anatomical textbook, they also classify this zone is root. Actually, it's also wrong because it's not root. I personally make a dissection of the postganglion root. It's only 5 millimeters. It's too short. You can neglect it. This is why I say there is actually no postganglion root, this anatomical term. This is correct. Spinal nerve, this zone is spinal nerve, it's not the root. My conclusion is there's no postganglion root, the anatomical term, because it's too short to be neglected. They move to the level of brachial plexus injury classification. As I mentioned, they're so complex. And so I, in 2013, start from the Chang'an Memorial Hospital. I say, using number instead of words. Level 1, inside the bone. If you want to see the nerve, you have to do laminectomy to see the bone, or you need to do the transfer process or fracture to see the nerve. Level 2 is inside the anterior scalenus muscle, inside the muscle. If you want to see the nerve, you have to remove the muscle. Level 3 is around the clavicle, supra or subclavicle. Level 4 is infraclavicular. Using the number, I say, words means number. Number means words. So my classification, because 2013 is start to use that, and 2018 is already established in our center. We always say level 1, level 2, level 3, level 4, instead of such kind of complex terminology. This classification has been uniform applied Chang'an and Wanhuang Hospital. Of course, I hope this classification can be accepted by all because it's become a general consensus because it's simple and easy. Then move to the level 1 injury. Dr. Lau is one of our PNT's peripheral nerve team, the member. He corrected my cases, especially focused on the C5. And he classified the level 1 injury into the 6th level, from the normal to the complete root of origin. P means the perfusion. P1 means the 25% injury. P2, 50% injury. P3, 75. P4 is 75% injury. P1, P2, that means the residual stump is still available. P3, P4 is being residual stump is not available. Sorry. This paper has been accepted by the Journal of Radiology. You know, Journal of Radiology is very difficult to be accepted. For example, if they write down like this, ventral root P2, dorsal root P1, then I say this residual stump, I will use that. I put no graft. If they say the C5 loop is ventral root is P4, dorsal root P3, that means the residual stump, you cannot use that. You cannot use that. Then move to the standard 3, peripheral nerve injury. People classify it standard classification, mainly in the external meshes. However, the standard 3 is very, mysterious. I like to say it's a mysterious injury. Many debates, many researches, a wide range undetermined, a crucial factor to determine timing of nerve surgery. And also, the more important is standard 3 start to have potentially to have upbrain reinnervation. This is once a disruption of endoneurium, then collateral splotting not only causes sensory to motor mismatch, motor to sensory mismatch, it also causes motor itself mismatch. We call the co-contraction. It also causes sensory itself mismatch and autonomic nerve system mismatch. This is one of the brachial plexus burst injury, which called the motor aberrant reinnervation sequel. One of example. Facial signage is also another one example of the motor aberrant reinnervation sequel. When central disorientation in the wrist median nerve service and repair is one of the central aberrant reinnervation sequel. You know, the Frey syndrome with abnormal sweating after the practical surgery is one of the examples of the autonomic nerve system aberrant reinnervation sequel. Because of that, so I moved it to the, the sentence 3 is one of the neurometrics. We're talking about the nerve fiber disruption. Sentence 4 is the nerve particle disruption. Sentence 5 is the nerve trunk disruption. Then move to the fifth one. About 3 years ago, people started to use the brachial plexus burst injury. Before, we always using the obstetric brachial plexus palsy to describe burst injury. I agree, because it is injury, trauma. So I agree this kind of the correction. Then move to the nerve transfer and neurotization. Sometimes they are not the same. Because from my point of view, nerve transfer is kind of neurotizer. When you say neurotization is kind of the target, you can say intercostal nerve transfer to the musculocutaneous nerve. You also can say musculocutaneous nerve neurotization with intercostal nerve. But you cannot say intercostal nerve neurotization of the musculocutaneous nerve, because nerve transfer is kind of a neurotizer. Then move to the 7 terminology change, nerve transfer. When you see the book, Dr. Klein, in his second version, he classified the brachial plexus injury, the source is extraplexus source, intraplexus source. Intraplexus source, he used the intercostal nerve belong to this, and the tricep branch is Samson. This is a Sobsek, the muscle, and also the machineal muscle or the oblique muscle. But I like to say they are not the plexus. They are beyond, because they're beyond the axilla. It's no more plexus. So I say intraplexus nerve transfer, such kind of this, we call intraplexus nerve transfer. Such as this extraplexus nerve transfer, if you have a spinal accessory nerve from the anterior approach, it's kind of the extraplexus nerve transfer. And I like to say such kind of beyond the axilla is kind of the cross-target nerve transfer. It's better. It's not the intraplexus source. You have to say this is a cross-target nerve transfer. It's kind of distant nerve transfer. For example, some say he using the back approach and have a spinal accessory transfer to the suprascapular nerve. I like to say this is a cross-target nerve transfer. Of course, there are another kind of transfer we call antegrade N2 side, that vertebral. Reverse N2 side, that is susamachino, N2 side nerve transfer. Then move to the 8th change in the terminology, function-free muscle transplantation. The first one who using this term is mental. Because the functioning means the muscle activity is following the nerve cut and repair. It requires a period of muscle innervation and reinnervation. When you say functional, that implies the muscle is well innervated. When you say transplantation, we always say limb transfer. We never say limb transfer. You say limb transplant, liver transplant. When you say transplantation, implies it requires vessel repair. And transfer may not need vessel repair. So from my point of view, FFMT, function-free muscle transplantation, is more precise and clear. Then move to the 8th change of surgical treatment. Start with the first one. Exploration of the peripheral nerve should be general. I mean, the exploration of brachial plexus should be generous, wide exploration. But manipulate the nerve should be gentle. As I say, treat the nerve like your girlfriend. I personally don't believe endoscopic or lobar assisted can treat the brachial plexus injury. Of course, you may apply this kind of the technique for early diagnosis and early treatment, but not for the brachial plexus injury reconstruction. Move to the 2. The so-called interfascicular repair is not suitable for the direct nerve repair. This is so-called interfascicular nerve repair. Actually, spinal nerve, when severed, you just shrink external epineuron, and you just suture the internal epineuron. That's all, maybe three or 4 stitches. It's not like this. So I say it's not suitable. But you can do nerve graft. They might manufacture such kind of nerve graft. You can use such technique. Then also the tension-free suture is also different from the tension-less suture. When you want to try to make a nerve repair, I mean the spinal nerve, you can trim external epineuron. Then you suture the internal epineuron with the 8 nylon. Then the external epineuron, you can make this kind of the traction suture to the dense tissue like a bone or like a periosteum, which called the tension-less suture. Anterior circumposition of ulnar, anterior circumposition on radial nerve, or do the fibroectomy to the peroneal nerve direct repair. Those is kind of a tension-less suture. But when you say the tension-free suture is essentially, you need a longer mobilization. If you want to use a through nerve graft, you at least 10% longer to make a tension-less. Then talking about the neuroma management. Neuroma may be such kind of small neuroma, such kind of big neuroma, such kind of hourglass deformity neuroma, such kind of impinged by the bone, there's no neuroma, or such kind of the long duration. This one, after the dissection, becomes this one. It's after a long dissection. This is long nerve duration neuroma. I'd like to say, if it is short spinal shaped neuroma, less than 3 centimeters, then you do neuritis. Maybe sometimes you do neuritis and nerve graft. But when you see the like a more than 10 centimeter long spider shaped neuroma, no need to do neuritis, just resection and the nerve graft. Big neuroma like this, the same, resection. Hourglass deformity, from my point of view, just resection. Resection, no matter 1 hourglass or 2 or 3 hourglass, resection and the nerve graft. You don't need to do the neuritis. What about the total root of origin and the incomplete root of origin? What kind of surgery? Here I show you some cases, good cases and the bad case. This one is a C6 of origin. Then you can use the C5 to C6. This is so intraplexus nerve transfer. Then you can do the frenal transfer and the posterior diffusion C7. This is so-called intraplexus nerve transfer to the C5. Excellent result. No co-construction. Actually, this is a movie. It has been checked. I don't know. Actually, it's a movie, and it doesn't need waiting. Very strong. This is my fellow, Frank Fang from the United States. He's checking the patient. This is another interesting case. The C5 rupture, C6 to T1 root of origin. You can see the Horner sign. You can see the scapular bone paralysis. The way I do is very simple. Just C6 within the vascular graft to the oral side. I always reconstruct the oral side, musculocutaneous nerve and the median nerve. Then also frenal suprascapular transfer for the shoulder. This is for the hand and the elbow. After get the result, the second surgery is just arthrodesis of the wrist and thumb. This is my fellow from the United States. He checked the shoulder, he checked the elbow, he checked the finger, she checked the finger. You can see he has a very good, he actually supination contracture, but when he elevated the elbow, by gravity, it becomes the pronation, so supination pronation. And also the elbow function is actually good, and he actually can hold ice cream. He can use a normal hand to extend, you see, to extend the finger. Then you can hold it, then he can eat ice cream. One surgery. It's just one surgery, then arthrodesis. Total root of origin. I prefer multiple nerve transfer. This you can construct this C7. This is hypoglossal nerve. This is spinal system nerve from this transfer, including the brain nerve, intercostal nerve transfer, infraclavicular brachial plexus exploration, and the vascularized ulnar graft harvest. I show you this, just one surgery, 5 years after, Frenner spinal system transfer for shoulder, intercostal transfer for elbow, contralateral system transfer for hand, get the shoulder, elbow, and hand. As I mentioned, I already constructing the oral side. I don't reconstructing the extensor side. Another case, one surgery, Frenner transfer for shoulder, intercostal transfer for elbow, and the contralateral system transfer for the hand, shoulder, elbow, and hand. This is also a very interesting case. I just separate. The first one surgery, spinal system Frenner transfer, get the shoulder, intercostal transfer, get elbow. Patient ask more. Then I do the pedicle vascular graft to the contralateral C7 to the median nerve. Then second stage, function-free muscle. Separate the stage. And he has get a good result. He can, control the shoulder, elbow. He has some wrist extension. He sees the ECIO function. Because of Frenner to the distal C5. Distal C5 through the posterior division upper trunk. So he get the ECIO, wrist ulnar deviation extension. Of course, he also can hold the target. I just showed the movie. This is the bad case. I saw the patient is already 4 years after surgery. One doctor do many things. Spinal system transfer, contralateral C7 transfer, function-free muscles for the many surgery. You can see the many scar here. But the only here is no brachial plexus exploration. I saw the patient, this is already 4 years after the big surgery, 3 times big surgery. I checked the patient. I know this patient is incomplete brachial plexus injury. So you see, level 1 is okay. But the rupture is level 3. Exploration also shows what I see, what I predict. So I like to say, make just comment. The patient had a big suffering. The patient had a big functional loss due to the wasting the C5, C6 functional nerve. The surgeon should be condemned because it's misdiagnosis and no brachial plexus exploration. No diagnosis, no treatment. When I say diagnosis, including the 2 kinds of diagnosis. One is a preoperative diagnosis, one is an intraoperative diagnosis. This is preoperative diagnosis. You have to complete all the chart, motor, sensory, and including the history, including the present ear needs. Yeah. And this is the so-called intraplexus diagnosis. You transect the stump to see this is a healthy stump, a stable stump, or poor stump. So my second comment is, to the physician, if you cannot make a preoperative accurate diagnosis, you better refer the patient. To the surgeon, if you cannot do the intraoperative diagnosis, you better not do the surgery. Regarding the total rule of origin, there are 2 philosophies. One is IP4, multiple nerve transfer. I already mentioned the cases. And one is the Doi method. He using the 2 function-free muscle. Because there's the multiple nerve transfer is kind of the proximal to distal reconstruction because shoulder and elbow, the first priority, hand is then hand. But the Doi method is distal to proximal reconstruction, hand, elbow is first, then shoulder. So I personally prefer this kind of the multiple nerve transfer for the total rule of origin. So in complete rule of origin, brachial plexus exploration is still essential, I like to say, and required, because this is kind of the diagnosis and treatment. However, distal nerve transfer is only for treatment, no diagnosis. You may miss the proximal spinal nerve. Proximal nerve graft transfer are benefit, especially for shoulder. Of course, you can combine both methods. So brachial plexus exploration, I say, can achieve more muscle recovery. Look at this page, C5, C6 nerve graft. Look at the deltoid muscle, the recovery of deltoid muscle, also recovery of the supinator and recovery of brachial radialis. That come from the C5, C6 nerve graft. Brachial plexus exploration can avoid unnecessary nerve transfer. Look at this patient. I explore, actually this branch to the lateral cord is intact. So initially drop elbow, but I did not do anything. This elbow is come back by itself. The lateral cord was still in continuity. It's thundering stream. Another case, Before, actually, I did not do anything. The shoulder just elbow flexion recovery just by itself. This is by ENT surgeon who do the surgery. I explore because drop shoulder, drop elbow, 4 months. So I explore, I do the C5 neuritis only. The shoulder come back by itself. But distal transfer is you can show the rehabilitation and quick recovery. We know that. But however, still have the encoded motor and sensory deficiency. 3 years after, grip power still weak. This is the machinometer. You see after such kind of the transfer. 3 years after, it's still weak, the grip power. Even in this case, 9 years after, the ulnar still no recovery. It's still no recovery. So my comment is, proximal transfer is traditional surgery method, benefit for diagnosis and treatment, especially important to check C5. They can simultaneously restore the shoulder elbow function, even the forearm. Of course, you can decrease the iatrogenic injury. However, distal transfer is still a new surgery, but you can combine. For example, this case, drop shoulder, drop elbow, you combine. You do the proximal for shoulder, then you do the machinometer, 2 fascicular transfer. Also can get a good result. Look at this, the deltoid. Look at the supraspinal, infraspinal recovery. That's because you do the proximal nerve graft. Then move to the Brachial myocutaneous flap. People worry about the skin flap survival. But I like to say, if you want to have a skin flap, you better include the adductor longus fascia, of course, brachials. Some people also advise adductor maculus fascia also include. So this is a septocutaneous perforator. It's not a myocutaneous perforator. So when you design on the muscle, it's wrong. You have to design the skin between the muscle, adductor longus and the brachials. This is a septocutaneous perforator. You can harvest the big flap. You can harvest like a small skin monitor, skin flap and monitor. This is my case, facial paralysis. You see, you can separate. It's only based on the septocutaneous perforator. This is the skin flap survivor and also for the face reanimation. Sometimes you can harvest like this. This is perforator, septocutaneous perforator, go to the skin monitors. Very rare you can see such kind of perforator, very rare, but sometimes you can see that. So my comment is, the brachial musculocutaneous flap, you better use a septocutaneous perforator. The last one, deltoid muscle, because confused, deltoid muscle recovery is overlapped with the supraspinatus muscle. So I like to say, the precondition, every time you want to check deltoid muscle, you have precondition. You have to make sure deltoid muscle is movement. Then you see the movement. Then you see the M1, M2, M3, M4. This is the precondition. You have to see deltoid muscle movement. For example, after this kind of reconstruction, axonal nerve graft, you see the deltoid muscle movement. Because you see the deltoid muscle movement, then the patient can move like this, then you can say this deltoid muscle function is M3 or M4. Like this. You can see the deltoid muscle movement and the patient elevation the shoulder about 60 degrees. This is M3. Conclusion. I may take too long time to my presentation. Anyway, I have no conclusion. I just hope this talk can energize your interest in the brachial plexus injury diagnosis and treatment. Thank you very much.